Hello, my name is Kevin Corcoran. I'm president of Corcoran Consulting Group. Today we're going to discuss ICD-10 fundamentals. This program is presented in two parts. This is part 2. ICD-10 is important to ophthalmologists and optometrists because the proper diagnosis code is an essential element of claims for reimbursement, and ICD-10 takes the place of ICD-9 for most payers. At this point, the viewer should have an appreciation for the scope, organization, and workings of ICD-10. Now it's time to apply the guidelines, conventions, and instructions to the practical process of finding a code. The process of finding a code owes much to the heritage of ICD-9. There are many familiar points. We begin with general guidelines. Diagnosis codes are to be used and reported to the highest number of characters available. Signs and symptoms are acceptable when a definitive diagnosis has not been established by the provider. Do not code diagnoses documented as probable, suspected, questionable, rule out, or working diagnosis, or other similar term indicating uncertainty. Multiple codes may be required for a single condition that affects multiple body systems. Principal diagnosis should be based on the condition that prompted the visit and was the primary focus of treatment. Code all documented conditions that coexist at the time of the visit and require or affect patient care, treatment, or management. Do not code conditions that were previously treated and no longer exist. To start, look up the main term in the alphabetic index. Scan subterm entries if needed. Review continued lines and additional subterms. Then, note parenthetical terms that help with code selection but do not affect code assignment. Pay attention to the following index instructions. See, see also, and see category cross-references. With and without notes. Omit code notes. Due to subterms. Other instructions found in note boxes such as code by site. Do not code from the alphabetic index without verifying the accuracy of the code from the tabular list. Read all instructional material including includes and excludes notes. Use additional code and code first underlying disease. Code also, 4th, 5th, 6th, and 7th digit requirements. Consult the ICD-10 CM guidelines for use of specific codes. Confirm and assign the correct code. There are 21 chapters in ICD-10. Ophthalmology and optometry will use many of the chapters and not just Chapter 7. They are Chapter 1, Certain Infectious and Parasitic Diseases, Chapter 2, Neoplasms, Chapter 3, Diseases of the Blood and Blood-Forming Organs, Chapter 4, Endocrine, Nutritional, and Metabolic Diseases, Chapter 5, Mental and Behavioral Disorders, Chapter 6, Diseases of Nervous System, Chapter 7, Diseases of Eye and Adnexa, Chapter 8, Diseases of Ear and Mastoid Process, Chapter 9, Diseases of Circulatory System, Chapter 10, Diseases of Respiratory System, Chapter 11, Diseases of Digestive System, Chapter 12, Diseases of Skin and Subcutaneous Tissue, Chapter 13, Diseases of the Musculoskeletal System and Connective Tissue, Chapter 14, Diseases of Genitourinary System, Chapter 15, Pregnancy, Childbirth, and the Puerperium. Chapter 16, Newborn, Perinatal Guidelines. Chapter 17, Congenital Malformations, Deformations, and Chromosomal Abnormalities. Chapter 18, Symptoms, Signs, and Abnormal Clinical and Lab Findings. Chapter 19, Injury, Poisoning, and certain other consequences of external causes. Chapter 20, External Causes of Morbidity. Chapter 21, Factors Influencing Health Status and Contact with Health Services. To illustrate how to find a code, we start with a straightforward case involving cataract. Within the ICD-9 system, what is the appropriate code? A, 368.8, blurred vision. B, 366.10, senile cataract unspecified. C, 366.16, nuclear sclerosis. D, 366.14, posterior subcapsular. The answer is C, 366.16, nuclear sclerotic cataract. What is the appropriate ICD-10 code for this case? As we learned earlier, we begin in the alphabetic index using the term cataract as a starting point. Both nuclear and sclerotic are adjectives of the noun cataract, so we would not expect adjectives to be the main term to look up. Under the major term cataract, we find a number of terms, and not surprisingly, nuclear is one of those. Of course, these are in alphabetical order, but indented to show that they modify the major term cataract. Next, we see that nuclear is likewise followed by indented terms that further modify the major term cataract. Of note, the term sclerosis has an instruction. See cataract, senile, nuclear. Our search needs to continue a little bit further. Since senile follows nuclear in the alphabet, we look further down the page to find it. Senile has many indented terms below it, and one of those is nuclear, with a parenthetical term sclerosis after it, and the direction to look in the tabular list starting with H25.1. The small hyphen indicates an incomplete code that needs more characters. We can expect to find those in the tabular list. Moving to the tabular list, we start with the category, H25, age-related cataract. We note the excludes to instruction and determine that it's not relevant for this case, so we move on. H25.1 is further down the page, indented, and contains the description we want, age-related nuclear cataract. To finish our code selection, we see 4 more indented codes below H25.1 that describe laterality. In our case, the patient has cataracts in both eyes, so H25.13 is our best choice. The fact that we are only operating on one eye does not change our diagnosis of bilateral nuclear cataracts, but it may be very significant when we code the operative report later on. Starting with the printed ICD-10 handbook is a good way to appreciate the new code set, but it's not the only way to find a code, and it's certainly not the fastest way. There are computer files to help you, known as GEM files, which stands for General Equivalence Mappings. These tables convert, where possible, ICD-9 codes to ICD-10 codes, and vice versa. Regrettably, they are imprecise mappings and not crosswalks. If translation from one set to the other were straightforward, there would be no need to change systems. These public files are free and available online at the CMS website. There are 2 files in text format, ICD-9 to ICD-10 and ICD-10 to ICD-9. Each file contains code pairs, where possible, 1 from each set. When you open the file, you will find 3 columns of numbers and characters. There are no descriptions or any instructions. We will not discuss in detail the information in the 3rd column. It contains flags for computer programmers. A flag is set when the number 1 is present and not set if the number 0 is present. If there is a flag, it's telling you that the codes are approximate, or there is no map, or it's better represented with a combination code. If there is 1 in the flag column, pay attention, as there could be other attributes to the code mapping. For this case, since we know the ICD-9 code is 366.16, we use the GEM file for converting ICD-9 codes to ICD-10. Note that H2510 appears in column 2 next to 36616. Also, there's a flag set. The number 1 appears in column 3, so this answer is an approximation and not a precise code selection. To complete our assignment to find the right ICD-10 code, we use this information as a starting point to enter the tabular list. Then, in due course, we'll arrive at H25.13, but a little bit faster than using the alphabetic index. GEM files have some use, but are far from perfect. The ICD-10 handbook, in print or electronic version, is the ultimate source. Other useful aids include inexpensive and numerous apps for smartphones, tablets, and laptops. Other online resources can help you find ICD-10 codes. One of the most powerful lessons to learn is you can only code what's in the chart. Coders are stymied by missing information or ambiguous notes. For ICD-10, that means the history and the impression must be well done. Otherwise, a code cannot be assigned. Think about your charts. What changes are needed? How will you change habits to improve documentation? Is your assessment specific to which eye or eyelid? Does your chart note list both the disease and the associated manifestation? Is the impression as specific as possible for a particular condition? Legacy charts are remarkable for brevity. ICD-10 leads to a requirement for more detail. It all begins with the history taking. Diabetes will require more detail at intake. Injuries will require detail on how they are caused. Hypertension coding is affected by other factors, such as tobacco use. If a patient has 2 diseases, a combination might change the code. Patients with HIV need to be coded carefully, and much depends on the presence or absence of symptoms. Chart notes within the history of present illness and family history become more significant within the context of ICD-10. For many ophthalmologists and optometrists, current chart notes are insufficient to select a code. This is one area that will need some work. Chalazion left eye is weak. Chalazion left lower lid is better. BDR-OU is weak. Type 2 diabetes with mild NPDR without macular edema taking insulin is better. Iritis OU is weak. Chronic iritis OU is better. Hyphema, right eye is weak. traumatic hyphema, right eye, is better. CME is weak. CME, right eye, after cataract surgery is better. Ptosis is weak. Mechanical ptosis, OU, is better. Cataract is weak. Nuclear sclerotic cataract, right eye, floppy iris syndrome, adverse effects of Flomax is much better. Let's go through a series of helpful hints to improve your diagnosis coding. First, use the most descriptive code possible, the one that's farthest to the right. Next, correlate the primary diagnosis with the chief complaint. Next, list chronic or secondary diagnoses if pertinent. Next, code with symptoms if there's no definitive diagnosis. Next, don't use diagnosis codes that no longer apply. Lastly, use systemic disease if no ocular disease is present. Now let's take a few seconds to check your comprehension of the key points in this program. You can skip the following few questions if you're in a hurry, but come back later on and try them. GEM stands for A, generally equal material, B, gross equivalent meaning, C, general equivalence mappings, D, graphic equivalency materials. The correct answer is C, general equivalence mappings. Which one of the following notes in the medical record cannot be used to select an ICD-10 code? A, glaucoma OU, B, POAG, mild stage, C, glaucoma with pseudoexfoliation, severe stage, D, glaucoma steroid responder. The correct answer is A, glaucoma OU. The chart note states conjunctivitis OU. This is an example of a diagnosis which A, must be coded with an unspecified code, B, must be coded with an other code, C, must be coded with a NEC code, D, cannot be coded. The correct answer is A, must be coded with an unspecified code. Your patient presents with pain around the eye. After a thorough exam, you're unable to find the etiology of the pain and suggest an appointment with the patient's primary care physician. It is acceptable to use the diagnosis of pain around the eye for this encounter. Is this true or false? The correct answer is true. The primary diagnosis should comport with the patient's chief complaint. Is this true or false? The correct answer is true. Your patient presents with a slight decrease in vision in both eyes. He has a family history of AMD, so you are suspicious that he may have AMD. Your exam reveals mild cataracts in both eyes and healthy retinas with no sign of AMD. Your primary diagnosis code is A, mild cataracts OU, B, AMD, C, family history of eye disorders, D, disease suspected, not found. The correct answer is mild cataracts OU. I hope you enjoyed this brief program and that you learned the fundamentals of ICD-10 coding. For further information, you may want to view another one of our e-learning programs on a related topic. If you have questions or concerns about this program, you may call us at 800-399-6565 or email us at our website. This program is a discussion of ICD-10 fundamentals and is not intended to be comprehensive in nature. You are encouraged to review official instructions by CMS, This program is not an official source nor a complete guide on reimbursement. The viewer is reminded that this information can and does change over time and may be incorrect at any time following its production. Thank you.